So if we start by the order of the public health problem, what do you think leads to that degree of undertreatment of mitral regurgitation? Maybe Dr. Chhatriwalla could comment on that.
So, one thing I noticed in our practice is that that comment again that the patients are coming out of the woodwork. When you start a MITRAL program, then you start to get referrals from your partners or from the community, and you understand better how long physicians, whether it's primary care physicians, cardiologists, how long they've been sitting on these patients who they don't feel are good surgical candidates. They, many times they never make it even to a cardiologist, much less a cardiac surgeon for assessment or evaluation. I think that, when you look at some of the data that I presented, I think we don't know exactly how few people or how many people get therapy. These are estimates, these are extrapolations, but I think the amount of people that are not referred simply because there's not a good option in the first place is more than you imagine. Once you have good options, then you get referrals, and then you see which patients may be eligible.
Yeah, we just analyzed that, and what we observed is that of people diagnosed in the community by echo with mitral regurgitation, only 15% on their lifetime will have surgery for mitral valve disease. So it is an enormous degree of undertreatment, even in the community, our community, which has everything. So you walk and you can have an MRI, a TE, a cardiac surgery, you can have anything. And there's an enormous degree of undertreatment. And so that's our impression locally, but we never see these patients coming to us in some way. The echo is done and forgotten. And I wonder if this is South Minnesota only, or maybe northern Minnesota is the same?
Northern is like southern. And I would say that under-penetrance it's very common, and I think it's the title of the talk is what it is, because when you look at this disease and the prognosis, I mean, it's like cancer, and I think if we had 85% of patients with breast cancer being undetected and untreated, we would be held out to we'd be hung publicly. And so I think there's a real call to attention that needs to be made for this, and I think it's on us to help draw that attention to what needs to be done. Yeah. I'm not saying we have an answer for how to solve or improve the prognosis of all those patients, but I do think that there needs to be greater attention to the fact that it does portend a poor outcome.
Carlos, New Jersey, or Rakesh, what's the how do you find that your system for detecting and referring MR is for you?
I think at least in New Jersey and New York, both, I think there is a tendency to sit on those patients by the primary cardiologist. They do not want to send those patients to surgery at an earlier stage. And really the reasons I don't understand. I don't know if this is all on the basis of outcomes or is on the basis of cost. And that may be primarily the main.
And you know what troubles me in this thing is that a guy alone is deciding in the visit of 10 minutes total the fate of a patient. And you say, how can you do, it's very hard for us to make this decision together, and then in the general practice, the guy has a total of 10 minutes and is making a life decision.
Absolutely. I think this is the issue. I think the problem is that we have historically decided in one man being the judge and the jury for every single patient that he sees. And I think you brought it up in your talk, that basically we're moving into a decision-making process that the reimbursement, the cost of this is going to change the way that practitioners are working today. You're going to be penalized heavily on your reimbursement, on what you're getting, by not doing the right decision. And one single man alone cannot make the individual decision in these pathologies.
You know what's interesting to me to this day, whether it's in Rochester, Minnesota, or Cleveland, Ohio, or in the Middle East, is that there's still a significant proportion of not only internists but cardiologists who simply don't understand the data. It's really remarkable, and it's not a judgment against them. I mean, I think that the fields have become so super specialized that to really understand what it means to refer, let's just say, a Class 2A degenerative MR patient, asymptomatic, high functioning, like anybody else in this room. That's what they look like, right? They come in, they're professionals, they have families, kids, jobs, friends. To refer them for an intervention or surgery is just not at the top of people's minds in general. And that's what surprises me day to day in clinic. And I pull out the paper, I pull out your papers, I pull out the Cleveland papers, I pull out the JAMA paper, and I go through it, and they're like, wow, I didn't know this stuff. So I don't know what it's going to take to get that information more widely disseminated amongst even our cardiology colleagues.
Ted, do you think that the guidelines should include that deciding for complex things like the treatment of MR, the patient should be referred to a heart team?
We're trying to simplify an immensely complicated discussion. So I think if we separate DMR and FMR, the discussions are completely different. And Rakesh, you lament the patients, the asymptomatics who are not getting a good evaluation, but I think that's a very small part of the big universe of where we have missed the center of the target. I think there's a problem with symptomatic DMR patients not getting referred because of a lack of understanding of the data. On the FMR side, suggesting that there's a treatment gap, that we have to have proven that something works before there's a treatment gap. So there's lots of patients, they're not treated. But we have not carried the ball until very recently with trials to establish effective therapy for the FMR group. One of the biggest problems I believe we have, and Maurice was just touching on this, is educational. So we come to our meetings and we talk to each other, and we don't go to the American Academy of Family Practice or the internal medicine group or any of the primary care meetings, or even, for that matter, communicate effectively with our colleagues at ACC or the general cardiology meetings. So I think education is a bigger gap than guidelines.
Yeah, I agree.
And to the idea, Maurice, of everybody should be seen by a heart team, I think this is like mom and apple pie. Of course everybody should be seen by a heart team. We have enough trouble getting through our TAVR TMVR list with 20 people in the room for an hour every week who are not being compensated for the time.
Yeah.
Well, we're all under pressure to see patients and do procedures and whatever. So if we saw everybody, we'd spend the whole week in the heart team meeting and never treat anyone. I'd also amplify that point for Rakesh's really beautiful presentation on his robotic outcomes. And literally, what are there, 10 people in the world who can do this that well? Seriously, 20?
You would say one.
Well, but it's a very small number, and if you just take the total annual mitral repair in the U.S., if we say there's 20 people in the U.S., which is way more than there are who are doing good robotic or even just good repair, we're really going to have those guys doing 20 apiece a day, every day, to get the U.S. annual volume done. And we have another failing there, that we've got our surgical community averaging 2 repairs a year, mitral, and we're working hard to try to replicate it in the TAVR world with having every site on the planet doing TAVR.
Yeah, no. I think we haven't found a way of screening the patient, not just screening the patient, but evaluating and saying, really, this is somebody for whom we have nothing, and the people where we have a potential solution, and a lot of these patients have potential solution. Now, Rakesh, tell me, you're also in a managing position. There is the money issue. Payments are not so great. So maybe the panel can comment on how does a hospital system decide to invest in those mitral repair replacement technology, and how we're going to go in the future?
Well, importantly, these are the macro forces I see in healthcare, not only in the U.S. but globally. Based on the work of Michael Porter and Bob Kaplan at Harvard, there's been traction gained in governmental circles that'll be paying for population health management and cycles of disease care. So understanding diseases from pre-diagnosis almost, prevention, early diagnosis, early management, early intervention, and then longitudinal follow-up. So if you think about putting in systems, echocardiographic screening systems, and triage systems that'll get patients to treatment earlier, I see this as coming, and I see this as part of a capitation-based system that'll be rolled out through the U.S. Obviously, governmental factors will play into this, but I think this is the direction that I see things going. So I don't know if that answers your question, Maurice, but I think that I think the next level of sort of comprehensive treatment advance we're going to see in the mitral space will await these changes in healthcare payment to be put into place.
If I could just add, so as somebody who works in an integrated healthcare system at Kaiser Permanente, so it's a very different model. The point that was very well made about compensating each of the 20 members in the heart team room is very, very valid. And so that stress is actually taken off in our model. So each of us is salaried. None of us really has RVU markers or benchmarks or anything. Our time has to be accounted for. So we have to be working. We can't just not be at work. But what the system values, and our system is a little bit reluctant to new technology and expensive technology, especially when it can be $20,000, $30,000, $40,000. But the point that we have to make is that doing these therapies and offering these novel technologies will reduce the long-term healthcare costs. And so as implanters and investigators, we make the point that this will reduce readmissions for heart failure. If we treat patients earlier, they're going to have better long-term outcomes. And our system has actually been quite responsive to that. And so we found that even in a capitated system, it can be quite successful at reducing overall long-term costs.
So that's a good point, and I remember now what Maurice was specifically asking me based on once you identify the patient, how do you get them to the right technology, right time, right provider, et cetera. I agree with you, removing the incentives associated with volume and changing the pivoting towards value is going to be important, but it's also important to shoot down the misnomer that technology needs to be highly expensive and it needs to come at a premium. I've shown you two papers today, one in JAMA and one in Mayo Clinic Proceedings, where we demonstrated that actually over the total cycle of care, the cost of robotic mitral repair, for instance, and I believe a similar narrative will subsequently emerge with percutaneous mitral therapy, when done at the right time in the right place by the right people, on the right patient, will actually demonstrate a cost saving. So I think there's no choice but to continue to invest in novel technologies. I think that this will improve value for patients and payers.
So what do you think, Paul? The comments on a hospital healthcare system letting you do what you think you should be doing, or restricting your access to those technologies?
It's a difficult challenge that we see a lot. You know, the idea that all physicians are the same and provide the same type of care for a patient with any given condition, whether it's MR or some other valvular disease, it's a very difficult concept to digest. It limits the incentives for innovation, which innovation is almost always a loss leader. Even with MitraClip, and I know there are people from Abbott in the audience who are here and know this, the hospitals take penalties for doing clip procedures if you look at it per patient treated. And it can be difficult, but it's a valuable investment because it's part of the whole program, and it brings value in many other different ways. So I think it's a very difficult question, and I'm not sure how to address it going forward, but just know that there are challenges when we're trying to innovate in this space.
Any burning question to the panel for mitral technology, new things to be done? It is, my last sentence, it's going to be very big. because only a small fraction of people with mitral valve disease are treated. We're going to have devices that are going to be effective, and it's going to be an enormous segment of treatment. I have no doubt. How we're going to get there, I'm not sure, but it's going to be gigantic. Well, if there are no other questions, thank you so much.